So today we will be discussing about cervical pathology, and the main topic of the cervical pathology is undoubtedly the cervical cancer. So main focus will be on that, especially I will be focusing more on how we approach to the disease, the screening part and the diagnosis. Okay, every aspect regarding the cervical cancer is the most important for you. So let's start. So these are the basic contents that we will be discussing. Mainly first about the physiology, you all know, and what is the important regarding this pathology part I will be discussing, and then we will discuss about a very small topic, acute and chronic cervicitis, then types of cytology, cervical cancer and premalignant lesion, their pathological aspects, as I have already said, screening and diagnosis, then at last summary and discussion. Okay. Summary will be given by those are sitting in the back benches. Fine. Okay. So cervical pathology. So you know the cervix is the joining part between the uterus and the vagina. Okay, and the cervix has two parts. The outer side is known as ectocervix and the inner side is endocervix. Obviously, ecto means that is outside and endo means which is inside part, right? So this is ectocervix and endocervix. So ectocervix is the basically the epithelium is a continuation of the vagina, and endocervix is the continuation from the uterine cavity. So that is why the ectocervix is lined by the squamous epithelium, stratified squamous epithelium, and the endocervix is lined by the simple tall columnar epithelium. But interestingly, there is a connection point between them which is known as transformation zone or squamo-columnar junction. Squamo-columnar junction because the outer side, from outer side there is squamous epithelium, inner side there is columnar epithelium. So the joining part is known as squamo-columnar junction, transformation zone, and this part is what exactly the point where when we do pap smear, this point is of very significant importance. Okay, so because during the collection of the sample, this part is what we focus more and try to take samples from this part mainly. And physiologically also, this is an example of metaplasia. Now who will tell me the definition of metaplasia? Any specific? Okay, sit down. I am telling you the exact definition. Okay, so you repeat after me and lock it in your mind because this is very important. Metaplasia. Okay, so it is a type of cellular adaptation where a adult or mature type of epithelium is replaced by another mature or adult type of epithelium due to regeneration of the stem cells. So this is the complete definition. Okay. So it is a type of cellular adaptation where a mature or adult type of epithelium is replaced by another mature or adult type of epithelium due to regeneration of the stem cells. It is always mature or adult type, same only. It is replaced, and what is the mechanism? It is basically because regeneration of the stem cells. Okay, so this is how you remember, right? So as I have already told you that all during studying systemic pathology, always go back to your general pathology and try to correlate with this. Okay, so this is how you study and correlate. Okay, so now let's go to the pathology proper. We will start with acute and chronic cervicitis. Very simple and small topics. As it is cervicitis, itis means inflammation, right? And inflammation can be acute or chronic, mainly two types. Okay, so basically what are the acute inflammatory cells and what are the chronic inflammatory cells? From head to toe it is constant. If there is acute inflammation, there will be that type of cell only. If it is chronic inflammation, it will be that type of cells only. So acute inflammatory cells, remember, mainly are neutrophils, and chronic inflammatory cells are mainly lymphocytes and plasma cells. Okay, so everywhere it is same. So but in acute cervicitis, what are the causes associated with purpurium? Do you know what is purpurium? It is the 6 weeks time following childbirth. Okay, so during that time the cervicovaginal canal is very prone for this infections. So what are those? So basically the gonococcus, herpes simplex, they are the most common causes. Okay, and what we will be seeing the grossly while examination, the cervix will be swollen, that is edematous. There will be some reddish appearance और also everted. Everted का मतलब क्या है कि ये फूल के थोड़ा बाहर की तरफ आ जाता है. Okay, so this is what everted is. So this is what you are going to see during your clinical examination. And on histomorphology, simple acute inflammation. So you will be seeing the neutrophils. So in the subepithelium there will be neutrophilic infiltration mostly, right? See the image under this epithelium. So the cells you are seeing now, so all of them are neutrophil. So there will be dense neutrophilic infiltration here. So that is why it is acute cervicitis. And another thing, that part is known as ulceration. Okay, ulceration is basically when the surface epithelium is denuded and underlying there is acute inflammatory infiltrate, neutrophilic infiltration. So this is your known as ulceration. So during the acute inflammation, acute cervicitis, you can also see ulceration also, right? Now chronic cervicitis can be associated with normal vaginal flora infection. In which condition you think the normal vaginal flora that is present in our body can affect, especially when the body's immunity is compromised. Okay, in case of diabetics, like, and also in the old age people, okay, elderly females, they are very prone for developing this normal vaginal flora induced chronic cervicitis. So it is very common. Okay, so what are those? Those are streptococci, enterococci, staphylococci. They are normal vaginal flora and they can cause chronic cervicitis. Apart from them, definite pathological organisms are your trichomonas, gonococci, herpes simplex and candida. So Candida albicans induced chronic cervicitis is very common in case of diabetic patients. Okay, they present with vaginal discharge that looks like thick cardi. Thick cardi vaginal discharge is your clinical presentation of those chronic cervicitis because of Candida albicans, very commonly seen in case of diabetics. Okay, and grossly morphology during the examination, vaginal examination, it more or less same only during acute and chronic, but in the histomorphology there is the difference because it is a chronic inflammation. So we will see lymphocytes and plasma cell. Itna hi hai bas. Okay, so any kind of inflammation if it comes in the exam, always remember what acute inflammatory cells are, what chronic inflammatory cells are. If you forget everything also, you can write this and you will be still be correct. Okay, this is the basic. And sometimes wherever there is chronic inflammatory cell collection, that is lymphocytes and plasma cell, they tend to form their colonies which are known as lymphoid follicles, right? So the lymphoid organs, you know that lymph nodes, spleen, there are lymphoid follicles normally present. Okay, but in any part of the body, if there is a excessive chronic inflammation, lymphocytes are aggregating. In those parts also, they tend to form follicles. If they form the follicles, we call it follicular inflammation. In this case, we will call as follicular cervicitis. You have studied chronic cholecystitis also. One of the morphological variants is follicular chronic cholecystitis, is not it? Follicular cholecystitis में भी same होता है. ये lymphocytes, ये लोग ये follicle बना लेते हैं. So that is why we are calling it follicular cholecystitis. See the diagram. You can see in the left part. So this is a follicle. This is the aggregates of the lymphoid cells. So this is a follicular cervicitis. Apart from them, dense inflammatory cells inflammation, they are mainly mononuclear cells, lymphocytes and plasma cells. Okay, so this is all about your acute and chronic cervicitis. A little bit recapitulation of the types of cytology. You already know, you have already studied FNAC and pap smear. So basically these things only. What are the types of cytology that you have to remember? one is exfoliative cytology. When we study the cells that are normally shed or exfoliated, like in the cervical canal. So this is known as exfoliative cytology, and this is the basis of your pap smear. Mainly the conventional pap smear is the basis of this exfoliative cytology. Then comes aspiration cytology. Here the cells are not exfoliated. You know, you have studied fine needle aspiration cytology, where you are inserting a needle inside a tumor, okay, or a swelling, and you are aspirating out, you are pulling the cells out of that lesion. This is known as your aspiration cytology, and then you are making it smear. Okay, so this is exfoliative cytology, aspiration cytology. What is imprint cytology? Suppose you have a lesion on your head, okay, and you take a glass slide, you touch on that part, and the material you are getting, you are making a smear with it. This is known as imprint cytology. Okay. Then effusion cytology. We have pleural cavity, peritoneal cavity. There are when there is collection of the fluid, it is known as pleural cavity pe collection of fluid, pleural effusion. Peritoneal cavity pe collection of fluid, ascites. Okay, and when you are studying the cells of this effusion fluid, this is known as effusion cytology. Last comes liquid based cytology. From anywhere that you are getting this kind of cells, if you are not processing it directly, you are dispersing them in a preservative solution, liquid preservative solution, and after that you are processing indirectly. This is known as liquid based cytology. So these are the types of the cytology that you need to remember. There are a few other types of cytology as well. One is crab cytology and also squash cytology. As I have already told that, suppose a hand lesion is there and you are touching it and making a smear, that will become a imprint cytology. But if you had to scrap it, scrap through a slide and make smear, then it is going for scrap cytology. Suppose you are getting a small tissue, you take one slide and above the another slide, you are crash it in between the smear, you crash it in between the slides and making a smear. This is known as squash cytology. Okay, so it's basically the nomenclature is about how you are processing it for cytological examination. Okay, so these are the name types of the cytology that at least names you have to remember. Okay, now cervical canal classification. Cervical cancer, mostly epithelial tumors that we are concerned with. There is the most common ones: squamous cell carcinoma. There are precursor lesions known as H-cell and L-cell. L-cell is low grade squamous intraepithelial lesion. H-cell is high grade squamous intraepithelial lesion. Then adenocarcinoma epithelial. Also in the cervix, these two are mainly that we are concerned with. Okay. Apart from this, in cervix also there can be neuroendocrine carcinoma as well, and also mesenchymal tumors. Those are very rare, but still if you can remember the names, it is very good. So beneath this epithelium there are smooth muscle also, is not it? The uterine smooth muscle is continuous with the cervix only. So the smooth muscle malignancy, benign is known as leiomyoma, smooth muscle tumor malignant is known as leiomyosarcoma. Okay? But our interest is mainly squamous and adenocarcinoma, very highlightably squamous cell carcinoma. What are the risk factors? Early age, first intercourse, multiple sexual partners, high parity, high risk HPV. HPV is full form of HPV? Human Papillomavirus. Remember that most notorious serotypes of HPV is 16 and 18. That is what we are mostly concerned with. Human Papillomavirus 16 and 18. Human Papillomavirus 16 and 18. And you know what is the most interesting part? HPV is the is a very important pathogenic factor in developing of this cervical cancer, right? And we have vaccine for HPV. Okay, it is very commonly practiced now also. So HPV vaccines, two vaccine I would like to tell you about. One is Gardasil, another is Cervix. Gardasil, Gardasil, and another one is Cervix, Cervarix, Cervix. So Gardasil and Cervix. Question alert. There can be explained why question. Why cervical cancer is preventable? Okay, because there is a vaccine available we have. So suppose this question comes, then how are you going to answer this question? You have to answer starting from the pathogenesis, the role of HPV in the pathogenesis of the cervical cancer. Then you have to mention these vaccines that I have told you that is available according to this. So that is why it is vaccine preventable, which makes it overall preventable, because HPV is the most important factor in the pathogenesis, right? So this is how you are going to answer. Now, very important slide for you. Okay, so not only theory question, MCQ, everywhere it comes. Okay, in any part of your exam, whether you are getting in the just PCTs, whether it can be your internal assessment, whether it can be university exam, these questions to definitely will come. And so many times the MCQ has come from this topic, uncountable times in the NEET PG as well. What is this? This is the pathogenesis of HPV. Now listen to me very carefully, I am going to explain it. What happens with HPV? The human papillomavirus, when enters in our body, it combines with the genome. First, there is a combination of the genomic DNA. Combined ho gaya. Now HPV has two oncoproteins. Oncoproteins means those are cancer causing proteins, pathogenic proteins. One is E6, another is E7. There is E2 also, but it has lesser role compared to the E6 and E7. We have two very prominent tumor suppressor genes in our body that prevents from many cancers. One is TP53, also known as the guardian of the genome. It is also an MCQ. Guardian of the genome is known as TP53. Okay, so TP53 one, guardian of the genome, and second one is RB gene, retinoblastoma. This RB gene has come from, the name has come from, you all know, retinoblastoma malignancy, from the, you already have studied, retinoblastoma in the eye. So the retinoblastoma, from this the gene has come, because it has so much role to play in the pathogenesis of that cancer. Not in that only, but in the many cancers in our body, RB gene is affected. Okay, so second one is retinoblastoma. TP53 has direct inhibitory effect on carcinogenesis, cancer development पे direct inhibitory effect इसका है. So that is why it is a major tumor suppressor gene known as guardian of the genome. Retinoblastoma क्या करता है? It is the master regulator of cell cycle. Master regulator of the cell cycle. Why? There is one transcription factor known as E2F. Every transcription factor उसको फ्री रहना होता है सेल साइकिल आगे बढ़ाने के लिए. E2F का भी फ्री रहना, एक्टिव रहना ज़रूरी है ताकि ये ट्रांसक्रिप्शन कर पाए, सेल साइकिल आगे बढ़ पाए. कोई भी अगर कैंसर सेल है उसको रोकने का जिम्मेदारी रेटिनोब्लास्टोमा का है, क्योंकि अगर E2F फ्री हो गया तो वो ट्रांसक्रिप्शन करेगा, सेल साइकिल चलता रहेगा, प्रोलिफरेशन होता रहेगा, कैंसर बढ़ता रहेगा. दिस रेटिनोब्लास्टोमा इनएक्टिव्स दैट E2F, उसको पकड़ के रखता है, E2F को जाने नहीं देता, एंड सो कार्सिनोजेनेसिस इज halted, it is stopped. Now what E6 and E7 does? E7 जो होता है, E7 बैठ जाता है रेटिनोब्लास्टोमा के ऊपर. Now when this attached with the retinoblastoma, it cannot no longer hold that E2F. Now E2F is becoming free, and because E2F is becoming free, the cell transcription will go on, or there is carcinogenesis. Understood? E7 inactive करता है retinoblastoma को. Now what does E6 do? E6 is direct destroyer of this TP53. इसको डायरेक्टली डिस्ट्रॉय कर देता है TP53 को. तुम्हारा गार्डियन ऑफ जीनोम गया, मास्टर ऑफ सेल साइकिल रेगुलेटर गया. नाउ देयर इज कैंसर. ओके, ऑलवेज देयर इज अ इनहिबिशन ऑफ द ट्यूमर सप्रेसर जीन लीड्स टू कैंसर, राइट? सो बाय दिस टू mechanisms, human papillomavirus is causing cancer, cervical cancer. You will remember this. At least remember the E6 inhibits and destroys the TP53, E7 inactivates the retinoblastoma gene. Okay, so this is very important for you. कभी भी अगर आए एग्जाम पे पैथोजेनेसिस जो कि आएगा, ये फ्लो चार्ट यूज करना, ठीक है? Now pre-malignant lesion, always before there is malignancy, sometime the body gives a hint that this is pre-malignant state. You intervene at this point, otherwise there will be invasive carcinoma. Okay, so what are those called in case of cervix? They are CIN 1, 2, 3. CIN is cervical intraepithelial neoplasia. Okay, now remember that HPV always affect the basal epithelial cells. First is the basal epithelial cells of the epithelia, there is involvement. From there carcinogenesis start or dysplastic changes starts. If from the basal part the involvement is up to 1/3 of the epithelium thickness, this is known as CIN1 or mild dysplasia. If it reaches up to 2/3, this is known as CIN2 or moderate dysplasia. If it goes beyond that and involve the whole thickness, this is known as severe dysplasia. So severe dysplasia CIN3 is also called carcinoma in situ. You know what is carcinoma in situ? It is basically when the dysplastic changes has taken over whole of the epithelial thickness, but invasion is still not there. क्योंकि इन्वेशन अभी तक नहीं है तो हम लोग इसको कार्सिनोमा नहीं बोलेंगे, इसको हम बोलेंगे कार्सिनोमा इन सिटू. यहाँ पे CIN3. क्लियर? नाउ बेथेस्डा सिस्टम होता है रिपोर्टिंग के लिए सर्वाइकल पैप्समियर में. अभी इनको इंटीग्रेट कर दिया गया है इन दोनों को, ठीक है? तो इन द साइटोलॉजी मोस्टली वी हैव बीन कॉलिंग इट एलसील एंड एचसील. नाउ इट हैज़ बीन इंटीग्रेटेड विद द CIN. नाउ एलसील जो होता है, जैसा कि मैंने बोला, लो ग्रेड स्क्वामस इंट्राएपिथेलियल लेशन इज कोरेस्पॉन्डिंग टू दैट CIN1 माइल्ड डिस्प्लेशिया, एंड HCIL हाई ग्रेड स्क्वामस इंट्राएपिथेलियल लेशन इज corresponding to both CIN2 and 3. ठीक है? So there can be short notes also in cervical intraepithelial neoplasia that you have to mention, which is what? Up to 1/3 level CIN1, up to 2/3 CIN2, beyond and involving up to the whole thickness is CIN3 or carcinoma in situ. And Bethesda reporting system cytology के साथ हम लोग अगर इसको integrate करेंगे, so LCIL corresponds to CIN1 and CIN2-3 corresponding to HCIL. स्क्रीनिंग, तो अगर हम लोग एक्सफोलिएटिव साइटोलॉजी करते हैं इस पार्ट का, वो तो सेकेंड पार्ट में आएगा, लेकिन देयर आर विजुअल इंस्पेक्शन मेथड्स ऑल्सो. विजुअल इंस्पेक्शन विद एसिटिक एसिड एंड लुगल्स आयोडीन स्क्रीनिंग. तो विद एसिटिक एसिड इट इज नोन एज VIA, विजुअल इंस्पेक्शन विद एसिटिक एसिड, and villi, one which is known as visual inspection with Lugol's iodine. If we are inspecting with the acetic acid, so there are some pathological areas that we see during the clinical examination. They are known as acetowhite areas. You see those areas? The pinkish area is the normal area, but these whitish areas are not normal. They are corresponding to dysplastic changes. Okay, and these are known as acetowhite areas under VIA. Okay, so VIA पे हम लोग अगर विजुअल इंस्पेक्शन करना चाहते हैं तो कुछ ये ऐसा दिखेगा. दिस इज नोन एज acetowhite areas. And now if we want to proceed for cytology, mainly focusing on the transformation zone, with that exfoliative cytology that we are going with the Bethesda system and It is known as pap smear with the pap stain. Now the Bethesda system has these reporting categories. Okay. First is NILM, which is negative for intraepithelial lesion or malignancy. If you are not finding anything that is pathologic, still very much normal, then we are going to report as a category NILM, negative for intraepithelial lesion or malignancy. LCL and HCL I have told you already. Okay. And if there is excessive evidence of malignancy, invasive malignancy like necrosis and hemorrhage, one of those features, we are going to call it directly as squamous cell carcinoma. Okay. So this is how it is reported. In between there are two gray zones. Okay. When we are not able to call it normal, but it is not LCL also. That gray zone is called as ASCUS, atypical squamous cells of undetermined significance. Okay. This is the gray zone number 1. Second part, we are not able to call it highly dysplastic as HCL, but it is not LCL also. That part we are calling it as ACH. It is known as atypical squamous cells where HCL cannot be ruled out. Okay. So this is how it is being reported. At least remember the names of them. I am not going into the detailed criteria of their diagnosis because it is not required at your level, but remember the names only of this Bethesda reporting system. Okay. So this is how it looks like in the microscope. The first image on the left hand side is your normal squamous cells. So they are normal cells only. Okay. So they are normal cells. In the second part, there is low grade squamous intraepithelial lesion, and if you can recognize these whitish areas around the nucleus, they are known as perinuclear halo or whitish zone, and this change is called as coilocytic change or coilocytic atypia. It is mainly seen in case of LCL, that coilocytic atypia, that dysplastic nucleus with a perinuclear halo is known as coilocytic change. Okay. And this part you see the dysplastic changes are pretty more evident here also. It is compare this with this and this. See, these are normal, this is low grade, and this you see the dysplastic changes are very high, irregular nuclear contour, high NC ratio. So these two are high grade squamous intraepithelial lesion, HCL, and this is LCL. Okay. So this is how it looks in the cytological examination in the pap smear. So this is again a cartoon diagram. First is normal, and the normal epithelium also in the histo. So it is basically correlating cyto and histo diagrams, right? So first is normal, it is a normal histology also, normal cytology also. This part is CIN1. See, the dysplastic change are mostly seen in the basal epithelium. It is LCL, CIN1. CIN2 and 3, you see the dysplastic changes beyond 1/3 up to 2/3, and here the whole epithelium is dysplastic. This is known as carcinoma in situ. Okay. So, and this is corresponding with the CIN3. CIN2, 3 are corresponding. So this is all about your cervical intraepithelial neoplasia and HCL, LCL. Real histodiagrams. First is normal, absolutely normal epithelium. Second one is LCL. Third and fourth are HCL. See those nucleus. You see the perinuclear halo whitish zones. So they are coilocytic change in the LCL. Can you appreciate it? Right. So this is HCL, where the dysplastic epithelium you can see through and through here also, and this is HCL in the form of carcinoma in situ. Whole thickness of this epithelium has undergone dysplastic changes. So this is your ultimate flow chart that is important. First, there is major risk factors. If there is a pathogenesis comes, then you write this. Okay, this is from the Hirschmohan. And after the HPV infection, high risk types, mostly 16 and 18, there will be integration, and first there will be low grade pre-malignant lesion. Now low risk virus are also there, which is known as 6 and 11. There is no genomic integration like 16 and 18, but there is only episomal infection. Episomal infection means it is staying in the superficial epithelium only. This is known as 6 and 11. And what disease it is causing? It is known as condyloma. Condyloma acuminatum. It is not going anywhere. So the condyloma acuminatum, if we manage it, so it is very much curable, and so this is caused by HPV 6 and 11. But 16 and 18 will be causing pre-malignant and ultimately malignancy. So the continuation of this chart is here only. So condyloma acuminatum undergoes ultimately regression, and from CIN 1 there will be CIN 2, 3, and ultimately there will be invasive cervical cancer. I always tell you, if there is a pathogenesis or any relevant question where you can use flow charts and diagrams, as much as possible you try to use. This will increase your scores in the theory. So always remember this point, right? So if there is a question on cervical cancer pathogenesis, so apart from that HPV E6 and E7 pathogenesis, you are also supposed to mention this flow chart. Okay, so this describes everything what is happening from the very beginning to the end. Pathology, not much to describe here. So basically two things that are two morphologies that we are seeing, one is squamous cell carcinoma and one is adenocarcinoma, right? Squamous cell carcinoma and adenocarcinoma, they are spread mainly through the, if there is lymphatics in the carcinoma, there is mostly lymphatic metastasis. Here there will be obturator and parametrial lymph nodes. If there is hematogenous route, though in carcinomas hematogenous metastasis is not very common, hematogenous metastasis is more common in case of sarcomas, is not it? But if it is has to be there, then goes to the lungs and liver. Okay. Now, who will tell me how the morphology of squamous cell carcinoma is usually described? I described it in the last class of carcinoma penis, no? Yes, you. Squamous cell carcinoma, how you morphologically describe? One feature is here only, very prominent. Bolo? Squamous cell carcinoma. Okay, so remember in squamous cell carcinoma, two important features, sit down. Two important feature, one is there, this is known as keratin pulse, not pearl horns, it is known as keratin pulse, and obviously there will be dysplastic squamous cells invading into the stroma. Okay, two things only you have to remember. One is your dysplastic squamous epithelial cells invading into the stroma, second is keratin pulse, right? In the cervix, they used to differentiate between them also. They used to call it keratinizing and non-keratinizing. Now it's all about HPV, whether it is HPV associated or not, that is what we want to know, because the management will be different. But morphologically they used to describe it as keratinizing and non-keratinizing. When this keratinizing feature will be there, this keratin pulse and all, we will be calling it keratinizing. If no keratinization are evident, but there are dysplastic epithelial cells only invading into the like in groups, cluster, nest or singly, whatever, we will be calling it is a non-keratinizing squamous cell carcinoma. Clear? Adenocarcinoma same. In the second picture shows malignant glands, dysplastic malignant glands invading into the stroma. So that is why it is adenocarcinoma. So main two things are there. Apart from the neuroendocrine carcinoma and all, they are also usually seen, but it is very rare in case of cervix. In which organ you have read neuroendocrine carcinoma? Commonly, lungs, bhul gaye? small cell carcinoma, small cell neuroendocrine carcinoma, large cell neuroendocrine carcinoma. So it is very common in lung also. GIT में भी होता है. Okay, so they are more commonly seen in those organs. In cervix it is rare usually, neuroendocrine carcinoma. Your most important focus will be in the squamous cell carcinoma and also adenocarcinoma. Adenocarcinoma में भी HPV का involvement होता है, ठीक है. So both of them are associated with HPV. But the premalignant lesion that all you have to know regarding squamous cell carcinoma. This is CIN 1, 2, 3, HCl, LCl. Okay. Now summary. Risk factors for cervical cancer.
First sexual intercourse at a young age.
Okay, very good.
Multiple sexual partners.
Yes. Anything else? Risk factor will also include HPV, no? HPV 16 and 18. This is also important. Okay, good. Sit down. Yes, you, the corner one. So, which serotypes are involved mostly in the cervical cancer of HPV? 16 and not 16, 17, 16 and 18. Okay, can you describe me the pathogenesis of HPV? How it is causing? Okay. How? RBG normally blocks the E2F from transcription, no? So RBG, if it is get activated, so E2F is free to go for transcription pathway, right? So this is how it is done. Okay, sit down. ठीक है, चलो. So the most important factor you have to remember are the cervical cancer only. The cervical cancer, your risk factors, it is pathogenesis, then the pathological classification in the histomorphology, premalignant lesions, CIN 1, 2, 3, CIN 1 corresponds to the LCL, CIN 2, 3 corresponds to HCL, okay, CIN 1 when the 1/3 of the epithelium is involved up to, CIN 2 up to 2/3 तक जाएगा, CIN 3 it can involve beyond that to whole thickness, right? That is known as also carcinoma in situ. Then here comes to squamous cell carcinoma and types of cytology. It is very important. Here we are most importantly performing is exfoliative cytology, then your aspiration cytology, imprint cytology, liquid based cytology, effusion cytology. Okay, what are the types you have to remember? Reporting system, Bethesda categories, NILM, LCL you know, HCL you know, excessively squamous cell carcinoma, बीच में दो grey zones, ascus between the NILM and LCL, atypical squamous cells of undetermined significance, LCL और HCL के बीच में ACH, atypical squamous cell where HCL cannot be ruled out. Okay, then come to your also visual inspection with acetic acid and Lugol's iodine. With acetic acid and Lugol's iodine, what we are going to see the aceto-white areas, okay, pathologic zones. Then why it is preventable cervical cancer, because the HPV has the whole pathogenic role in it and we are going to prevent it by vaccination. It is a vaccine preventable malignancy, okay, again MCQ, by Gardasil and Cervix. Okay, so this is how you have to read, and these are most important questions also. Okay, do you know who is he? Have you seen his picture in our department? Does anyone know? No quizzers here? Any prompts? Okay, we are calling it pap smear, no? The exfoliative cytology study and also the pap stain. Have your any questions arrived in your mind that why are we calling it as a pap stain or pap smear? Can be called anything, no? Suppose cervical exfoliative cytology smear, ये भी तो बोल सकते हैं ना, क्यों नहीं बोल रहे हैं? Pap stain, pap smear ही क्यों बोल रहे हैं? Because the picture you are seeing here is of George Papanicolaou. He is father of exfoliative cytology. The pap smear has come from his name only, Papanicolaou. he is the father of exfoliative cytology. So he invented this procedure of exfoliative cytology, and by doing this he is saving millions and millions of lives, because the screening, by the cervical cancer screening, the cervical cancer can be detected early, treated early, and patient can be cured. Okay, so I think very much appropriate of mentioning him in the thank you slide. Okay, so we all should thank him, and remember that Papa-Nicolau stain and pap smear has come from his name only, because he is the father of exfoliative cytology. Okay, that's the end of your class. Any query you have regarding today's topic?